Okay, good day, everyone. Welcome again. Today is our fifth webinar series for this year, 2025. We have three interesting speakers today, and starting off with Prof. Hideyuki Ishihara. He will be our chair for today's webinar. And we have two other speakers, Dr. Giulia and Dr. Dinh. And we have two discussants today, Prof. Konstantin and Prof. Danilau. So I think, and at the end of it, we will get to know wins from Kazakhstan, is it? So to start off with, can we start with, would you like to start off first?
Prof. Kato?
Prof. Kato, would you like to say something, or would you?
Oh, today's webinar is very, very interesting. And we add one learning point that is not actually the formal lecture, but also Professor Ishihara is very skillful neurosurgeon. So we're expecting this lecture. Of course, the two other speakers. Thank you very much.
Shall we start? Would you want to start first, Prof. Ishihara, or should we start with our guest speakers? You want to
guest speakers? Yes.
He wants to start first.
I would start first.
Okay, all right. So I'll just introduce Prof. Hideyuki Ishihara. Today is our chairperson for the webinar. He's also giving us one learning point. He's a professor and chairman, Department of Neurosurgery, Yamaguchi University, School of Medicine, Japan. And today he's going to talk about thrombectomy. Is it effective for medial vessel occlusion?
Okay. Now, can you see my slide?
We can see. スライドショーにしてください。
Okay. Can you see my slide?
まだ。
Oh, it's all dark.
We're waiting. It will load. Please wait.
Yeah.
No?
No.
今消えちゃってますね。さっき見えてたんですけど。
本当ですか。
Can you share it again, please? Can you share it again?
やり直しましょうか。
Okay.
Okay. Can you see my slide? Now?
Yes.
ちょっと声が小さいな、先生。
声が小さい。
もっとマイクに近づくとか。
わかりました。Okay. Today's my topic is thrombectomy is effective for MeVO. I don't know you perform thrombectomy or not, but today I will present about thrombectomy.
もうちょっと大きな声がいいな。
First, I would like to introduce a little about our institute. Yamaguchi is located west part of Japan. Here. Next prefecture is Hiroshima. Our hospital is located in an industrial city. Our department composed 12 neurosurgeons and 3 residents and 2 researchers. Last year, we had 340 direct surgery and 240 cases of interventional neuroradiology. In this, we performed 76 cases thrombectomy. 2 weeks ago, I visited Dhaka. There was a 4th ACNS interim meeting in there. This is our friend, Professor Wada. He presented about CEA, and we enjoyed with singer in Bangladesh. Okay, I start my presentation. This is a timeline of acute recanalization therapy. RCT in the red frame shows positive results and RCT in the black frame shows negative results. Initially, its effectiveness was not demonstrated, but in 2015, including Mr. Clean, 5 RCTs demonstrated the effectiveness for IC and M1 occlusion of early time window. And then Diffuse 3 and Dawn trial showed the effectiveness for late time window patients. And in 2023, Rescue Limit and 5 RCTs demonstrated the effectiveness even for IC and M1 occlusion with large ischemic core. And next target is medium vessel occlusion. It is called MeVO. MeVO is often defined as distal part of MCA, ACA, and PCA. This is a meta-analysis of the Hermes collaboration. These previous meta-analysis had shown that thrombectomy is effective for MeVO. Actually, we have realized its effectiveness. I show you our one case. This is 93 years old female. She suddenly developed left hem paralysis and dysarthria. She transferred to a hospital 3 hours after onset. Her NIHSS was 9 points. Diffusion weighted image revealed acute ischemic lesion in right MCA territory, and MRA showed maybe M2 occlusion. Perfusion MR revealed there are some penumbra areas, so we performed thrombectomy. Occlusion site is here, right M2 distal part. Microcatheter is introduced and go through the occlusion site. And opened stent retriever and retrieved. Just one procedure. We got TICI 2B recanalization. Not complete, but TICI 2B recanalization. Her hem paralysis improved after 2 days. She was discharged from the hospital 2 weeks later, able to walk on her own. Her modified ranking scale was 2. Her clinical course was good. However, this year 3 RCT thrombectomy of MeVO were published. These results were negative. This is the results of ESCAPE MeVO. In this study, inclusion criteria was within 12 hours after stroke onset, and NIHSS was more than 5. And in this RCT, MeVO was M2, M3, A2, A3, P2, P3. These patients were randomized to endovascular treatment plus usual care or usual care. Primary outcome was modified ranking scale. In this study, more than 80% was M2 or M3 occlusion. Especially, there were many M3 occlusion cases. The results of primary outcome is this. There was no difference in favor of functional outcome, but mortality was higher in endovascular treatment group. It was a disappointing result for us. From this study, endovascular treatment for acute ischemic stroke due to MeVO is rather harmful. This is my discussion. Benefits and risk may vary depends on the site. Thrombectomy is highly effective in M1 and proximal M2, but the more distal region, the higher risk. The more distal the region, the milder symptoms, so that the more distal the site, the effectiveness of thrombectomy reduces. This is the results of Rescue Japan Registry 2. This is an observational study. 372 cases of M2 occlusion were analyzed. As you can see, overall, endovascular treatment was highly effective for M2 occlusion. But when we see carefully, low aspects, low NINHS, and late time window, they were not statistically significant. So this is the conclusion. 3 randomized controlled trials published this year failed to demonstrate the efficacy of endovascular treatment for MeVO. The inclusion criteria may be reconsidered. Thrombectomy must be effective for MeVO, I think, but maybe we have to select patients. Thank you for your attention.
Thank you, Prof. Ishihara. That was, I think, very interesting, eye-opening. Starting off, I mean, I think we're all quite familiar with the larger vessels, but this medium vessel is something interesting and something we need to think about. Are there any questions from our discussants? Prof. Danila, Prof. Kostadin?
Thank you. Thank you so much for a brilliant talk and scientifically grounded lecture. Thank you. I just wanted to know what are the typical complications that occur in this type of surgery, and how do you prevent that type of complications? Thank you.
Yes. The distal part, when we retrieve the thrombus, arteries are stretched and sometimes happens subarachnoid hemorrhage. So we usually use aspiration catheter to M2 and to avoid the stretch the arteries. Okay.
Thank you so much.
If I can ask also a question about this technique that can be used. What is your preference to the methodology of retrieving the thrombus? Do you use more the stent retrieving or the suction techniques? The last escape you have mentioned, he is using the stent retriever. And stent retrieving is probably more injurious to the wall of the vessel. So is that maybe related to complications? How do you think about this? About
yes,
your techniques and
yes.
how do you think about that?
Yes, I think you are right. Stent retriever is more risky for subarachnoid hemorrhage, but stent retriever is we can get more recanalization. Recanalization rate is higher in stent retriever than aspiration adapt technique. So maybe we will have much more better device in near future, I guess.
Yeah. That is probably also related very much to the issue of the nature of occlusion. If we have the atherosclerotic type of occlusion, or we have the embolic type of occlusion, we will be facing practically two different types of tasks to compete with our device.
Of course. Embolic occlusion and atherothrombotic occlusion is very different, and in this study, most of the cases are cardiogenic cerebral embolism, I guess.
Embolic, yeah. Okay. The atriofibrillation cases that usually we.
Yes.
Thank you very much.
You're welcome. Thank you also.
Are there any more questions? Anyone?
Sylvia has a question, I think.
You have, Roger?
Yes.
You want to ask?
No,
Please.
there is a question in the chat box.
It's in the chat box, yeah. Okay, I'll just read the question. That's a great success with better outcome, and it was possible because of each arrival to facility and management. How is it possible for the late patient arrival to facility? This is from Sylvia from Tanzania.
I didn't understand.
Okay,
時間が遅れてから来た人はどうしますかっていう。時間内に来なかった。
Late time window.
Yes.
Exactly.
Of course, it may be difficult, but if you can evaluate with perfusion study, and if you check the penumbra, if the patient has penumbra, it must be effective to recanalize the vessels, I guess, even in the late time window.
From your experience, the longest one is how many hours?
Longest one is more than 24 hours. For the purpose of the
escape was 12 hours actually. Escape.
Escape is within 12 hours. Escape means yes.
But I like how you presented, Prof, because you did say from the beginning that you look for the penumbra area. So that's how I realized that you're not looking for the time, door time, that you're looking more for the penumbra. I guess that's the message you're trying to bring to us. Any more questions?
Yeah, if I may ask, Prof. Ishihara, the first case you showed, the index case, there was not much of a difference between the first pre-op and the post-op scan regarding the infarct volume. What do you think has led to the improvement in patient?
Sorry, the presentation case, my case?
Yes, yes.
Is she has some penumbra, so after the recanalization, we saved her some penumbra area, so she become better her neurological deficits, I guess.
Thank you.
Carol?
Are there any more questions from the floor? Okay, I guess thank you very much, Prof. Ishihara. Or maybe at the end we might get some key learning points from you. Would you like to take over the webinar now and share the webinar?
Yes, but sorry, I don't have the flyer, so
Oh, okay.
I don't know who presents.
Right. Okay. It's okay. It's okay, Prof. Ishihara. I will just introduce the speakers and then you can take over during the discussion. Okay. All right. So going on to our second speaker, it's great to welcome Dr. Giulia Meccariello. She's a consultant in neurosurgery, Department of Pediatrics, Pediatric Neurosurgery in Sant'Uomo Posillipo, Naples, Italy. And today she's going to present to us the role of neuroendoscopy in the treatment of pediatric brain abscess.
Good afternoon, everyone. Can you hear me?
Yes.
Yes, please.
Okay. First of all, I'd like to thank Professor Kato and Dr. Liu for their kind invitation. I'm trying to sharing my, okay. Can you see it?
Yes.
Yes.
Okay. So I'm Giulia Meccariello. I'm a pediatric neurosurgeon at Sant'Uomo Posillipo Children's Hospital in Naples and in Italy. And my talk today is about the role of neuroendoscopy in pediatric brain abscess. Brain abscess remain a challenge and a life-threatening clinical condition characterized by a high mortality rate and a morbidity rate reaching up to 17%. Recently, the European Society for Clinical Microbiology and Infectious Disease published updated guidelines on the treatment of brain abscess in both children and adults. In this paper, the author strongly recommended neurosurgical aspiration or excision as soon as possible, whenever feasible, for all patients. However, the optimal surgical strategy remains debates. The standard technique include barrel surgery and the open microsurgical excision. Barrel surgery involves puncture and aspiration of the abscess. This procedure that can be performed under stereotactic ultrasound or neuronavigation guidance is associated with a low morbidity and mortality rates, but carry a high risk of recurrence, reported in up to 20% of cases. By the other end, open microsurgical excision of both the abscess and its capsule has a lower recurrence rate, but is associated with a higher complication. Over the past decades, several papers have explored the efficacy and the safety of neuroendoscopy in the treatment of brain abscess. In 2008, one of the largest case series has been published by Jadab and colleagues, involving 23 patients successfully treated with this approach. Neuroendoscopy treatment has also been applied in case of mycotic brain infection, as illustrated in this case report, as well as in pediatric patients, as shown by this work of the Chinese group and by our team at the Pediatric Hospital of Naples. More recently, Fiorindi and colleagues summarized the potential of endoscopic treatment of brain abscess, highlighting, among other findings, a 100% positivity rate in microbiological sample that is a significant higher result compared to the approximately 63% positivity rate typically reported with conventional surgical strategy. The author actually hypothesized that the solid component attached to the pyogenic capsule provides a more favorable environment for bacterial growth and detox oxygen-deprivated purulent core. According to them, the neuroendoscopic treatment removing this solid layer can get a higher microbiological positivity and can explain the absence or recurrence observed in their series. In summary, the potential advantages of neuroendoscopic treatment are several, including the direct visualization of the abscess cavity, facilitating complete pus removal, the possibility to remove the more solid fibrinoid component that may be the source of recurrence, the ability to treat the multiloculated abscess, and a higher likelihood to identify the causative pathogen in microbiological sample. In our unit, the pediatric neurosurgical unit, we started neuroendoscopic treatment of brain abscess in 2012. In our practice, we always plan the trajectory and the entry point preoperatively using a neuronavigation system in order to reach the center of the abscess while avoiding vascular structures such as the cortical vein or eloquent brain areas. We typically use the GAB endoscope, which allows the use of an endoscopic ultrasonic aspirator that is a very effective tool for removing the more solid fibrinous component of the abscess. The surgical steps are as follows. We start by puncturing the cyst under neuronavigation guidance. After the initial puncture, purulent material is drained sample for microbiological investigation. Once the more liquid part is evacuated, we insert the ultrasonic aspirator and continue aspirating until the visual field is completely cleared. Finally, the white fibrinocaseous layer located between the pus and the capsule is carefully removed. Now I will show you some of our cases. This is a 10-year-old boy with a 10-day history of headache and fever. The CT and MRI scan reveal a large abscess in the right parieto-occipital region. And we propose a neuroendoscopic evacuation. This is the video of the planned trajectory on the neuronavigation station. And this is the intraoperative video. As you can see, once we are inside the cavity, we use the ultrasonic aspirator that is very useful for removing the purulent material progressively all inside the cavity. As you can see, the instrument is very effective in sucking the pus easily all around the cavity, avoiding bleeding and injuries to the surrounding structures. And in this procedure, it is essential the continuous irrigation to facilitate the complete cleaning and to clarify the visual field. After the majority of the core of the abscess is removed, step by step, we continue by removing the thick fibrinous layer that has to be detached and aspirated from the cyst cavity. And the procedure can be considered completed when the cavity appears macroscopically clean, as you can see at the end of the video, right here. These are the post-operative MRI control. The first one taken immediately after surgery, the other one at 1 month, and the second one 2 months at 2 months follow-up that show a very successful result. The second case involved a newborn with a Dandy-Walker syndrome who underwent ventriculoperitoneal shunting during the first week of life for hydrocephalus. 2 weeks later, due to a CSF infection, the shunt was externalized and antibiotic therapy was initiated. However, the infection persists and the MRI revealed a purulent collection inside the Dandy-Walker cyst. We initially decided to place an external ventricular drain inside the cyst to allow the pus evacuation and washing of the cavity. Nevertheless, another 2 weeks later, the collection persists, so we decided to proceed with the neuroendoscopic approach. This is the intraoperative video. As in the previous case, you can see that the cavity cyst is completely filled with this abundant fibrinocaseous material. And in this cases, it's very useful the use of the ultrasonic aspirator that can gently remove all the purulent material inside the cavity. Also in these cases, after the cavity is almost emptiness, we continued with the removal of the white fibrinocaseous layer that is located between the pus and the cavity, and we still continue until the normal brain parenchyma is clearly visible all around the cavity. And here is the final view. And this is the 1-month MRI that show a very satisfactory result. Endoscopic approach can be performed even if the endoscopic ultrasonic aspirator is not available. This is a case of a 14-year-old boy who presented with headache and drowsiness, and the MRI revealed a large frontal left frontal abscess associated with concomitant sinusitis. We started with the standard microsurgical evacuation of the abscess along with the frontal sinus cranialization, followed by intravenous antibiotics. However, 15 days later, the follow-up MRI showed an increase in the size of the frontal collection, so an endoscopic approach was proposed and carried out. As I told you before, in this case, the ultrasonic aspirator was not available in our unit, but in such situation, we can use the microforceps to progressively remove the fibrinous material from the cavity in a piecemeal manner, layer by layer, until the cavity is completely cleared. This procedure takes longer than using the ultrasonic aspirator, but a successful outcome can still be achieved. And these are the postoperative images that show an excellent result and no recurrence at 1 month. Finally, the last case involved a preterm newborn who developed sepsis due to serratia marcescens at 1 week of life, complicated by multiple brain abscess. In this case as well, we opted for an endoscopic approach, considering the young age of the patients and the overall fragility, with the goal of minimizing surgical invasiveness and reducing the risk of complication. The endoscopic aspirator was used, as you can see in the video, and the result was satisfactory as confirmed by the postoperative MRI. What is very important to notice is that the procedure lasted in total 29 minutes, which is very relevant. The short time duration time is very relevant in preterm newborn. In our unit, 7 patients have been treated with neuroendoscopic evacuation for brain abscess, including 3 newborn. All procedures were uneventful, with no need of further surgery and no recurrence observed during the follow-up. In conclusion, a neuroendoscopic approach appears to be a safe and effective treatment for brain abscess, both as first-line treatment or in case of recurrence. It is a minimally invasive technique that is particularly beneficial in newborn and younger children. The use of ultrasonic aspirator provides valuable support in evacuating this collection more quickly and effectively, and we always recommend the use of neuronavigation to ensure the accurate identification of the entry point and the trajectory, especially in deep-seated vision. Our experiences on this topic has been collected in a dedicated paper, which is now in press and will be published soon on child nervous system. Thank you for your attention.
Thank you, Dr. Giulia. Nice presentation, and we can well understand with the video. Is there any question? Dr. Giulia, do you have, how many cases do you have 1 year?
Well, can I ask a question meanwhile?
Sorry.
Well,
how many cases do you have?
For brain abscess or in general?
Abscess.
Abscess, I think it's about, actually after the COVID pandemic, we have a lot more incidents of brain abscess. They increase a lot, particularly from sinusitis and from the otitis. And they, in the last 3 years, yes, from 2022, we have 40 cases. From 2022. Yes. It's a very big increase after the COVID pandemic, but we are not treating all of them with endoscopy. We continue with the standard treatment with the sinus cranialization together with the ENT surgeon. But in selected cases, we prefer to perform neuroendoscopy, particularly in very younger, newborn, very small weight patients.
Maybe large brain abscess endoscopic surgery is more effective.
Yeah.
Yeah.
Yeah,
Okay.
it's more effective.
Okay. Thank you.
Thank you.
Is there any question?
I think Prof. Danilov, you have a question?
Oh, please.
Yeah, thank you. Thanks so much for sharing your experience. Now, I just wanted to know if there were any if you faced with any diagnostic errors in your experience. I mean, when you considered the lesion to be an abscess, and in fact, it was not an abscess. And the second question: in what cases, in your opinion, does endoscopic abscess removal have disadvantages compared to other surgical methods? Thank you so much.
Okay. About the first question, not in this hospital actually, but in my previous hospital, we had a case of abscess in the midbrain abscess. But actually, it was an abscess, but in the first MRI, in the first 3 MRI, the diagnosis was of cavernoma. So we actually didn't go directly in the operative room because we thought it was a cavernoma. So we just leave the time to the child to get better, to take some time. But actually, it worsened in the days, particularly with the dexamethasone. It was terrible. So we ended up in the operative room and we found out it was an abscess. It's the only case that I remember where something like this happened. About these disadvantages, what I think is very important is that for performing neuroendoscopy in this kind of patients, it is important to have an expertise in neuroendoscopy because often the patients are very small. We treat newborns, so you have to be familiar with the endoscope, how to use it, how to direct it where you want to go, and how to be sure that all the cavity is really cleared, or it's not useful. The endoscope is better to go with open surgery. Compared to the direct puncture, I think that the endoscope is better.
Thank
compared
you.
to the barrole.
Thank you for your opinion. Thank you.
If I may ask, Giulia, at what stage of brain abscess do you do endoscopy, and what stage do you consider an open surgery? Because you may have cases where the patient comes with a mass effect and is coning. So would you advise an endoscopic aspiration in such patients? And second question is, after the you have drained entire pus, do you give a antibiotic wash into the cavity to reduce the bacterial volume?
Okay, thank you for the question. For the first question, when there is a involvement of the sinus, we always go for open surgery first because we need to interrupt the communication between the sinus and the brain. About the sites, we actually like to go with the neuroendoscopy also in big sites and very clinically significant abscess. With the neuroendoscopy, I think it's a good option, even if the patient is not going so well. About the antibiotics, we usually wash inside the cavity with antibiotics and then continue with intravenous antibiotics in the weeks later.
What is your antibiotic policy, total duration?
For now, we use the standard that for us means 4 weeks of intravenous antibiotics plus 2 additional weeks that can be performed orally if the germ is sensitive to the oral antibiotics. What we would like to discover in the future if with a very good cleaning of the internal capsule of the abscess, we can shorten the antibiotics therapy. But for now, we are not doing it.
Thank you.
Yeah, we have a question from Prof. Anyaku. You wanna?
Yes, thank you so much, Dr. Sharon. Yeah. Thank you, Giulia, for the presentation. Good afternoon, professors. Good afternoon, my teacher, Professor Abida. Good day. Sorry, in the presentation, do you have any preference for the type of endoscope you use, 0 angle, 30 degrees, and all that. Do you have any preference in your work? Then, secondly, do you leave a drain post endoscopy? You leave a drain in the abscess cavity at the end of the procedure. Thank you so much.
Thank you. We generally use the 30-degree endoscope. Sometimes we generally have both in the operative room, so we can exchange with the 0-degree if it's needed. But generally, with the 30-degree, we can reach all the cavity in a satisfactory manner. About the drain, we don't leave a drain inside the cavity, never.
Hi, Giulia. This is Abida.
Thank you. Thank you.
Thank you.
Is there any location where you will not use the endoscope?
Brainstem.
Okay. Okay. No, so that case that you presented that you thought was a cavernoma and then turned out to...
but that was open surgery. I'm sorry, that was open surgery. Yes, we went there open surgery.
Rosalie?
Yes.
Yeah. So if
just I wanted to ask how Giulia sees the percentage of cases in which endoscope is not applicable, because that is an important issue about settings and readiness to treat them. The second point is, when usually evacuations of abscess occur, even with the best antibiotic therapy, there is a risk of recurrence. So how she sees the risk of recurrence, and was there any case? Well, she had 7 cases, probably everything went well, but is there any other experience that shows recurrences that require a second go there? So that was, and the third, maybe also Raja asked about that, and I will be also interested. There is apparently for endoscopy a point at which you need certain stability of the border of the abscess, the wall of the abscess, to the level of gliosis, which will allow us to evacuate it much easier with our manipulation inside. So at the early stages, is it really advised where there is still cerebritis at the margins and so on? So these are my actually 3 points that I would like to ask and to hear her comments. Thank you so much.
Can you just repeat the third one? Sorry.
How do you see the third one?
Yeah, the third one.
Stage as a pathological evolution, it starts with cerebritis, inflammatory lesion of the brain where the metastatic infection has developed, and then gradually it goes into liquefaction and the demarcation of the margins until actually develops into a very well-confined cavity with very stable margins of gliosis, which allow to manipulate with the endoscope safely everything. So at this point of evolution in which the abscess is observed on the imaging studies, do you have any margin at which you will say, okay, now it's safe to go with the endoscope and we don't have to go into excision? How do you see it?
Okay.
Yeah.
Well, I'm not sure I know the answer, actually. I think that at least the abscess we've treated were all very well demarcated, very clearly organized abscess, where we expected that the endoscope manipulation should be quite easy, and we also expected that at least a portion of the abscess should be more solid, and in that case, the suction with the ultrasonic aspirator could be useful to remove more gently, how I can say, this part that can be related to the recurrence. And about the recurrence, it's true our cases are just 7 cases, not enough. It's only a pediatric case series, but there are several papers, for example, the one of Fiorindi that I show you, they didn't have any recurrence in their study. So they are described quite good results, and it's kind of connecting the absence of recurrence to the removal of this thin layer that's sometimes more difficult to be related, at least with the puncture of the abscess. And the first question, Sorry.
How do you see the application as a percentage of all cases? Is there really a must to have an endoscope in both facilities, I mean, ready when you are going to operate or not? How is your estimation about the percentage that will be treated endoscopically of all the
Okay. I think it's 30%.
about
30,
30%.
30, up to 30, yes.
Thank you very much. Thank you very
Thank
much.
you.
It was very much helpful. Thank you.
Thank you.
There is one question from online. The question is from Tawasul Ahmad. Thank you for the nice presentation. He has two questions. What is the size of the neuroport that is used in the case of the ultrasonic aspirator? And the second one is how to select patients, either endoscopic or open.
Okay, about the second question, answer first the second question. As I actually already said, if there is an involvement of the sinus, we generally go strictly open because we have to really make a barrier between the sinus and the intracranial site. If there is an isolated abscess, not with the sinusitis, we can go with we can choose for the endoscope. We can prefer the endoscope, particularly for very young babies, because the blood loss is very important in these babies. So endoscope is very, very minimally invasive, and in case of deep-seated lesion. But can be easier because you don't have to cross a lot of healthy brain with your open surgery. About the size of the parts, in this moment I don't remember the exact size, but what is sure is that you need the bigger one endoscope. That's why we use the GAB, because the GAB is quite big as a working channel, and you can insert the ultrasonic aspirator. But I will let you know the exact size.
Thank you, Giulia. Are there any more questions? Okay. I shall go on to introduce the third speaker. Thank you very much, Giulia. It was, I think, a very nice and concise presentation. I think makes things very clear for all of us today. I'd like to call the third speaker is Dr. Dinh T. Phuong Hoai. She's a lecturer and neurosurgeon from Hue University of Medicine and Pharmacy, Hue, Vietnam. So she's a fellow in doing a clinical fellow in Fujita now, and she's going to do her presentation with us today. Dinh?
Yes, thank you, Dr. Sarah. May I share screen?
Yes, you may.
Can you see my screen? Yes. Thank you. Good. Konbanwa. Good evening, everybody. Today I'm presenting my clinical fellowship at Fujita Banta Hospital, and I'm Dinh Thị Phương Hoai. May call me Hoai, and I'm from Vietnam. I'm a neurosurgeon, so a lot of things I try to study, and they let me know many things. And I try to improve myself and in knowledge. Today I'm presentation is my fellowship in Bantane Hospital. So this purpose to train resident and younger neurosurgeons from the developing countries and to be exposed for the subspecialty and advanced techniques in neurosurgeon. So my speech content about the first is the overview of neurosurgeons in Vietnam, realities of the female neurosurgeon in Vietnam, and also the fellowship in Fujita Banta Hospital. An overview of neurosurgeons in Vietnam, history and development. Neurosurgery in Vietnam began in 1915 to 1916, and the first established at the Việt Đức Hospital. And Vietnamese Neurosurgery Society, VNS, founded in the 1995. And since 2000, international collaborates with the ACNS and WFNS. And three major neurosurgery centers in the north is the Việt Đức Hospital, and Professor Đồng Văn Hệ is the chairman of the VNS Association and the deputy director of the Việt Đức Hospital. In the central Vietnam is the Huế Central Hospital and Huế University Hospital. In the south area, we have the Chợ Rẫy Hospital. And a spawn procedure for the microscope, endoscope, neuronavigation, first a little bit. And the common neurosurgery disease in Vietnam is special head trauma because the motorcycle accident, auto accident, and TBI loss. Maybe around the 30, maybe around the 60 to 70%. And brain tumor absolutely is either meningioma or schwannoma. And hemorrhage and spine, you can see a lot of patients go to the hospital with disc herniation and spinal canal stenosis. But the aneurysm or AVM a little bit because the screening is not good. Realities of female neurosurgeon in Vietnam rare presence, and I only know one female in neurosurgeon as Chợ Rẫy Hospital, because trained after the neurosurgeon is trained to the neurology or ICU or try to research. And challenge faced by women, especially the balance of work and life. The long term for the operation, night shift, and also the emergency care. So maybe a lot of women train works after the neurosurgeons. And positive sign in future step. The few younger women like me choose the great determination, especially the ACNS WIN open new opportunities. So it's a positive side. And I'm very happy and lucky because I know the Yoko Kato International Foundation and to have the fellowship with 2 month duration and see support for the free accommodation and apartment and scholarship money. And how to apply, you can go to the website and you connect with the Takanori-san. He the secretary and he have a lot of fellowship and very important with the Yoko Kato sensei. And this here overview for the meeting room. Every morning we had a conference in here and staff office for the fellowship for the doctor and the practitioner nurse and outpatient. And this year show the neurosurgery conference from Monday to Friday and step by step from 1 to 5. And also fellowship table, timetable from Monday to Sunday. And Saturday and Sunday have lots of the conference, local conference, and you can go to together and emergency care. And with the fellowship, we had a conference for researcher and journal conference from the Thursday, and you need to hard working like me. And what you can learn, you can learn the management of neurosurgery care, computation, fluid dynamics, CFAD, and how to broach the aneurysm, and microvascular anastomosis, write paper, and go to the library. And also you developments of the organization's skill. This here some the disease, the common disease in the Pantane Hospital, intracranial aneurysm. Absolutely. MCA infection, trigeminal neuralgia, hemiphaseal spasm, and tumor meningioma, schwannoma, or pituitary adenoma. And also we had a chronic acute subdural hemorrhage and hydrocephalus spinal stenosis. And technique, you can study either clipping, microscope, microsurgery, and endoscope with MPD and applications, hemorrhage, aviation, embolization, and flow diversion with. This here show the overview operation room. You can learn with the Tanaka sensei in the endoscope, and you can study microscope and support with the navigation. And vascular intervention, you can study with Dr. Tanabe, and you can see in the some case with the AVM embolization. And the fellowship can study computational fluid dynamics to assess the rupture or not rupture aneurysm. And you can study by yourself. And this here the microclipping with the Professor Yoko Kato, and you can study with the endoscope MPD with the Dr. Komachu. And intraoperation options ICG, and you can make the 3D image before operation, endoscope, navigation, and neurophysiology monitoring support when intraoperation. And you can study the surgical instrument for the microscope or endoscope. And also hardworking day by day need to microvascular anastomosis. And Professor Yoko Kato support for the fellowship goes from the local conference. When I go to the Fuji Panta Hospital, I can go to the neurosurgeon tuber brain academics meeting and neuroendoscopy study group. And I can study it, the DBS in the Nagoya Central Hospital with the Professor Take Hayashi. And so good because I study a lot. And organization skill, you can study the seminar and conference and member of organization. And very lucky because I met the Professor Casper. And I miss the Dr. Kinoshita and Dr. Danilov. Especially, I'm very interested in AI. And training of resident and fellowship. And Professor Yoko Kato always teach lesson directly and advise to avoid mistakes during surgery, and explains very clearly. And I remember when she go to the operation room and Shichimon ga arimasu ka? It means that do you have a question? And she support many things, and so she have a lot of so they say in the answer a lot of questions from the fellowship. And also the food and traveling, Professor Yoko Kato, she provide a lot of snack and food noodle for the fellowship, and very delicious. And a lot of restaurants around the Bandane Hospital. And you can find some the food in India, Bangladesh, or Pakistan. And the language you can change Google Translate and transport very clear, very close in the Bandane Hospital in the same country. And in every weekend I go to the Nagoya Kato and the temple and the Ginza. And principle, of course, you need to hardworking and is respect for the elderly. It means senpai. Teacher, it means sensei. Clinic and self discipline and organization system. Once again, thank you so much. Kokoro kara arigatou gozaimashita. Kato sensei. I thank you so much.
Thank you, Dr. Dinh. Thank you for your presentation and introduction of the situation of Vietnam and the residency in Japan Pantone Hospital. Thank you for your introduction.
Yeah, thank you, Professor Ishihara. Maybe I had 3 years in the Hamamatsu University of Medicine and Pharmacy for the BSD, and have achieved the graduated the BSD in the Hamamatsu in the Shizuoka. And so after that, I'm very lucky because I met Professor Yoko Kato in the conference in the ACNS, and I hope to go to Kusibanta Hospital and fellowship with her, and she accept for me, and maybe I'm amazing. And now I staying here after finishing a PhD. And in Vietnam, I just either work in 2 years, so maybe I don't have a lot of experiment for the neurosurgeon, and now I need to study more and more. And I hope follow with the Yoko Kato sensei, and I try to study study more about the endovascular and especially the benign tumor, because the endovascular and aneurysm in Kusibanta Hospital very famous and common. And every day I study lots of case with the MCA aneurysm, ICA aneurysm. So very lucky to stay in here, and I want to share something about the Pantane Hospital.
Okay. So you are just only one woman neurosurgeon in your hospital. I hope
Yes,
you are success like Professor Kato.
yes.
Sharon and yes, Sharon, maybe Amida, any suggestion to her? Because Vietnam is maybe I think more than one, but I think she maybe the organize some win in Vietnam, I think, in future. Amida?
So
Amida,
they
please.
should observe more and more surgeries and get chances to do some, and try to learn more and more. If you want to come to India also, you are welcome. We will try to arrange something. And I think last time we were there, we met some more women neurosurgeons. I think you are encouraging more women to join neurosurgery now. Looking at you, they should do that.
Yes, thank you, Professor Sass. Thank you.
Yeah, I think from your presentation itself, I think we can all see that you are really, really passionate about your work, right? That's the right way to go. Okay, don't worry. All right, as long as you have that spirit in you, you will do well. All right, and then I think when you go back to Vietnam, you will definitely motivate more women, I'm sure. Okay, so the thing is, when you are now in with Prof. Kato, you're learning everything from her, not just the education part, the knowledge part, but also I guess you're also getting the feeling of how it is, the spirit part of it. So I hope you can carry it on. All right, and never give up. Never give up. Okay.
Yes,
So nice.
thank you, thank you.
So she's very serious, so never give up, I think. Very
Yeah.
strong woman.
And well, anyway, in Vietnam too, I think neurosurgery in general is still quite new, right? I mean, it has been there, but it is still developing, because I know most of the neurosurgeons there do trauma a lot, and a lot of the sub-specialized cases go to only certain centers, right? So I think you should, with what you've learned now here in Fujita, you can bring it back there, and then, definitely you can, sort of become better there, right? Because there are not many.
Thank you for me.
Anyone else want to say anything to Prof. Considine? Yeah.
Well, certainly, I'm impressed by her dedication, and I'm quite sure that she will be successful. I wish her all the best, certainly, and really to be persuading the environment around her that the future is incorporating female and male neurosurgeons on the same basis in all kinds of activities, and this is the only way in which neurosurgery can survive in the future. I hope that the learning of the role model of Professor Kato and the personalities around her, the women neurosurgeons, will be something that she has to definitely translate into the Japanese environment and contact all the female neurosurgeons around her about that. I really wish her a lot of success. All the best.
Yes, thank you. Thank you so much. Yes.
Ishihara-sensei, how many female neurosurgeons in your department? Or in your, yes, association?
We have six guards, neurosurgeons.
Okay, so how you can educate for them, or any differentiation on the man and the female?
Actually, there are no difference between male and female, and actually, woman is more active than men.
Yes, I think so. I think so. You're a good mentor, I think. Thanks so much. Maybe Daniel?
Yeah, thank you so much. I just wanted to thank a lecturer for a brilliant and comprehensive overview of fellowship, which offers a wide range of opportunities, as we clearly see. I just wanted to, of course, I want to give all the best to young neurosurgeon, and I hope she will be a great success. No doubts about that. I just wanted to know how many years does a neurosurgery residency last in Vietnam? And I wanted to know what was the most challenging part of your fellowship?
Thank you for your question. So the first question, maybe in Vietnam, I have 6 years for the medical student. After that, 3 years for general practitioner for the resident. And after that, you work in the hospital. So total year is maybe 9 years, but it's not focused on neurosurgeon. It's a general practitioner doctor. And the second question is the challenge. I'm not sure, but it's maybe the money because I come from the Vietnam, so the money is the big problem with me because you need to buy a lot of things in Japan, especially the living, go somewhere and stay in the accommodations, and especially Japan is so high price. So with me, maybe the money is the big problem. But beside here, I think it's the maybe different the language. For example, the English and Japanese. If you want to study more, you need to study Japanese language. So if I want to study more especially neurosurgeon, and I need to study the Japanese, and I think the barrier for the fellowship is maybe the language. But it's so cry because the Bantane Hospital, Fujita Bantane Hospital, Kato Sensei recommend for a lot of doctor and the nurse try to talking with the fellowship by English. So very good and easy for me to study. I think so.
Thank you so much. So your story is very inspiring example, and I wish you all the success in your career. Thank you.
Thank you so much.
Okay, so I think before we end today, we have getting to know our WIN, and this time around we will get to know our women in neurosurgery from Uzbekistan. So I think first I'll just introduce Mohira. Mohira, hi. So I think
Hi again.
so I let you take over the session and introduce yourself and your colleagues. Okay?
Okay. Okay. Yes. Hello, everyone again, and thanks to Professor Kato Sensei and Dr. Liu and Dr. Raja for inviting us and introduce ourselves. And here I'll wait. Yes, I will share my. Is it visible? Or can you see my slides?
That's right.
Thanks a lot.
Please start.
Okay. In this presentation, at first, for starting, I want to show our historical and famous places like such as Samarkand, Bukhara, and Hiva for information. And the Tashkent is the capital of our country, and this is our hospital, Republican Specialized Scientific and Practical Medical Center of Neurosurgery, the main and biggest hospital in Uzbekistan and in Tashkent. This is the biggest neurosurgical center, and it has 7 departments, separate 7 departments: cerebrovascular, endovascular, spinal, neuro-oncology, and skull base and pediatrics. And from 3 universities, all residents and master students are trained here. And for whole country, our total neurosurgeons is about 320, and almost 15 are women. And the first one is Gulnara Al-Hajjava. She works at an emergency hospital, in trauma hospital, and she is our professor. And Dr. Zara Aslanova works in neurosurgical center as pediatric neurosurgeon, and other 4 women neurosurgeons works in other cities and other hospitals. And here's our residents and master students, and one of them is from Kazakhstan. She is also doing her neurosurgical training in our hospital. And I want to invite all of you for our first Congress of Neurosurgeons, which will held on in the Hiva, 1st and 6th September in this year. Thanks a lot. This is all, and thanks a lot. It's a short presentation. Yeah. Our one of the women neurosurgeons is also here.
Yeah, can you introduce them, Mohira?
Yes,
Yeah.
Dr. Zara Aslanova also here, but she is not panelist. Can you add, please, Dr. Zara?
She's not here, is she? Or is she not invited?
She's here. She's watching, but not as panelist. She's in attendees.
Dr. Zara, is it?
Yeah, Dr. Zara, can you?
I'll promote her. Okay. All right. Okay. Is she the only one? Do you have anyone else?
No, she's the only one. I told them, but only she could join, I think.
So I'm actually promoting her. Doesn't see. Okay. Is she on? All right.
For you, is it possible?
Yes, yes, yeah.
Yeah, yes, she joined.
Hello, yes. Hello, Zara. Dr. Zara, are you there?
Good day. Yes, I'm here.
Okay. Yeah, it's nice. Can you introduce yourself and just tell us a little bit about you?
I'm a pediatric neurosurgeon and I work in the Tashkent and the Specialized Center of Neurosurgery. And Professor Shah and Professor Kato has already visited. And if I'm not mistaken, Professor Shah performed a wonderful brain tumor surgery in our center. And we all had the chance to participate and to see the surgery in our own hospital. Actually, we are all the students of the Professor Gulnara Alauddinova. She was on the slides of the Mahira. She was the first woman neurosurgeon. On the whole, we have about 15 women in our countries, and all of them work in different parts of our country. But we always meet on the meetings, country meetings. That's what I have to say. If you have some questions, we can answer.
Prof. Kato, would you like to say anything? Would you have any questions?
Yes, thanks so much. Do you have any discrimination in between the man and female?
No,
No?
I don't feel like we have any discrimination, but to say the truth, it's always a matter to have a family and to be a good professional in the neurosurgery, because you need to work extra time being a neurosurgeon, and at home you need to be a mom, a wife. That's the main issue as to me. But at work, we don't have any discrimination. If you are strong, then you're strong.
Of course. Yeah, it's the same program in Japan, I think. Well, thank you very much. All the best. Arigato. Sharon?
Abida, you want to say something since you've been to Uzbekistan? Anything?
No, it's a very nice and beautiful country, and I think they have quite a few equipments and they're doing good work. They have a very good OR. Some things they have, some things they still need to have, but they're doing good. I think I did a thalamic glioma or something there, I think.
Yes, in Glioma was. And I also was fellowship Professor Kato Sensei and Professor Abida also. It was very great. Thanks a lot. I learned a lot.
Yeah.
Thank you very much.
So it's so nice for both of you to join us today. I think it's great that we can actually get to connect with, from your, I think maybe even 5 years ago, even 7 years ago, we couldn't connect like this, but now it's great. It's great to meet everyone here every time. And I hope you continue to support and join our ACNS WIN too. Okay. All right. It's great. Is there anything else? Yes.
Sharon, maybe we can invite female doctors from Ishihara Sensei department. How do you think, Ishihara Sensei?
Yes, it will be
We
great.
can invite one of your female neurosurgeons from your department.
Yeah, maybe you can join us in one of our webinars. It would be great if you could present something. We would love to see your work in your hospital. Okay.
Of course.
Yes.
Thank you.
Please recommend us.
Yeah.
Okay.
And share your email.
Arigatou gozaimasu. Thank you.
Hey, what your excellent talk. Thanks.
Thank you very much.
So, Prof. Kato, you want us to say anything before we end? Or is it Prof. Ishihara? Would you like to say something?
Ishihara Sensei, please close your remark.
Okay. Thank you very much to all speakers and participants. I truly appreciate your insights, your questions, and your engagement. I look forward to see you again. So, thank you so much. So,
thank you very much. Sharon?
Thank you very much to all our three speakers and to the WIN Uzbekistan. We hope you all will be joining us again for next session next month. Take care and have a good week and a good month. See you all soon. Bye.
Bye.
Arigatou gozaimashita.
Thank you. Arigatou gozaimashita.